a primary screen algorithm, had an abnormal screen, went to colposcopy, had no CIN, so she's now on an algorithm that told us to co-test in 12 months. In 12 months, she still has a negative PAP, but an HPV-16 positive. What will you do next? Again, think of the rising red lines. This woman is at risk as long as HPV persists. So now we're going to send her back to colposcopy. It's been a year. She's still HPV positive. She needs to be evaluated for precancerous change. And if the PAP is ascus or greater or HPV is still positive, colp is indicated. So we have support for practice. We have changes. Everybody says, why is it changing again? But as we have increased data and support of practice, we have new options to bring the best screening and follow-up to women. So you now have options with the interval of how often to screen, be it cytology alone, co-testing, or primary, the age to start, and that difference between co-testing and primary was based on the Athena trial showing 30% of the precancer was in the 25 to 29-year-olds. But it hasn't changed for co-testing yet. That was based on data at the time. Complexity is high, highest, and lowest for HPV primary, and that's one of the reasons it's so well supported. Next, we look at the level of protection. HPV primary, if done every 3 years versus every 5. And that's where the critics of the draft from the US, I keep falling over those, but the US Preventative Services Task Force, that's the 5-year interval is what has a lot of thought leaders concerned. But it does lead to more colposcopy with the HPV primary. So counseling's never been more important, and I hope you take messages back to also your colleagues, because here we are in a time of great opportunity to find those women who are truly at risk and lower the prevalence of cervical cancer. Remember that most women will have HPV at some point, and we can never know when it got there. We're also helping women understand if you're positive, we're looking for old infection because that's what's significant. Persistent long-term infection doesn't mean your partner's been unfaithful. And most women who get HPV and have HPV do not develop abnormal cells or cancer. You know, as I said, it's not a time bomb waiting to go off. We need to reassure. We have an opportunity to prevent a cancer. It's preventable through vaccine. It's preventable because of that long 10 to 15 years from precancer to cancer. And we want to find those women, particularly with HPV 16 and 18. I've already talked about piggybacking messages. We want to help women who understand they used to get a PAP every year. They just never knew it was to find changes caused by HPV. But now that they're beginning to understand that, maybe we can also help them advocate for getting their sons and daughters vaccinated. So utilize written materials. There's lots of unbranded available to you. So in summary, the 2012 guidelines are meant to increase benefit, decrease harm. We don't want to overscreen, and we don't want to overscreen young women with lots of HPV and no cancer. PAP plus HPV or HPV alone, we're going to find those women who are truly at risk. Primary screening, a few hands went up, but we'll see because this may become the standard. And the majority of cancer in this country is in women who've never been screened or inadequately screened, so we need to reach those women, and that will have the greatest impact. So I say to you in closing, help spread the word for appropriate cervical cancer screening. There is a wonderful organization called Survivor, spelled CERVIVOR, which is bringing messages to women. It's very isolating. Everyone knows someone with breast cancer. Very few women not only know someone with cervical cancer, but they find out it's HPV, and it's a lot to handle. So Survivor is a great nonprofit if you're interested in bringing messages to survivors and helping spread the word. So in closing, and I'm glad this isn't the lunch program, nobody wants cancer. We know that, and so we need to utilize these tools. So let's get busy and we'll keep all the cervixes happy. So thank you so much for your attention, and I'll take a few questions.
I'll take questions. Raise your hand. Back here.
Never had HPV 16, went to colposcopy, had a negative colposcopy, was re-co-tested in a year, and is persistently HPV 16 positive and goes to colposcopy again. Are you implying that that woman is going to need a colposcopy every year for persistent HPV 16? Because that sounds dreadful.
Well, it sounds dreadful, but I think we could flip it and say how great it is that we have a woman at extremely high risk. I keep going back to, I showed you three times the rising risk of CIN2+ over years if you're persistently 16 positive. So it's the best thing we can do. And I'm never, I mean, as long as she's HPV 16 positive, she needs really careful workup. But she may clear. We know 16 doesn't clear as fast as other types or as the age goes up. There's a less robust immune response. But she may clear and she may develop cancer. So we need to keep doing it and reassure her if she doesn't have precancer and treat her when she does. Yeah.
Do you have a magic ICD-10 code for Medicare for getting HPV?
Well, that's a big problem, and I must share with you that I had a great experience, but I didn't really testify. I take that word back. I was on the Hill and actually spoke at a forum to try to get Medicare to cover HPV testing, and as of today, it's not done. So I will tell women, if I have a woman who hasn't been screened in years and years, the best thing I can do is an HPV test. And I will ask her if she's willing to pay out of pocket. And I know in some communities or clinics that's not possible, but that's the best thing I can do. Yeah.
I had a couple of comments. I'm really happy to hear you talk about the HPV testing going to 3 years, because with the co-tests, we've already had 2 people who had co-tests that within 3 years changed from negative to HSIL, so high grade. And everything's turning out okay for those people. One had a leap. But I've been very concerned about going 5 years with the co-test. Yeah. And a friend of mine who was involved in the Northern California Kaiser guidelines that came out before, she said even Kaiser was doing it at every 3 years because they weren't totally comfortable with that. And one other comment I had is I'm still finding cervixes on hysterectomy patients, especially if they really don't know their history for sure, even getting their surgical reports if I need to. So it is true, people do have cervix.
Yeah, and I spoke to that. Absolutely, we need to make sure there's no cervix. And in terms of the interval, co-testing was a 3-year, became a 5. And I know many of us are not comfortable with 5. It's a problem if you're in a setting where you have to follow the guideline, such as a Kaiser, but they are 3 years. And Walter Kinney, who's at Kaiser, is one of the leading people in this field. But I tell my patient, I'm going to retest you not sooner than 3 years. And I also look at, I see women who, and as much as I tell them, I want to see you every year, even the years you don't need a PAP and HPV. I put it on their result card, see me yearly, even the year you don't need screening and so on. I still have patients who they don't hear it. We have to keep pounding it in. But I also look at the fact that I have women who haven't been in it's 3 years, and if I don't do it on that visit, it could be 3 more. So we have to make clinical judgment sometimes. Yes?
I have some questions here. Someone says the practice they're at repeats co-tests at 6 months instead of 12 months, once with positive HPV, even if a negative PAP. Is that also not a good practice?
The guidelines are based on significant amounts of data, and the data says PAP negative, HPV positive, if it's the first round, to repeat both tests in 12 months, unless genotyping is available. Because if she has 16 or 18, she's now in a subset of women much higher risk than being HPV positive for a panel. We've already identified. So again, there's no support for a 6-month follow-up, but a 1 year if HPV genotyping is unknown. And if known, she gets immediate colposcopy.
Okay, can you
Yeah.
comment on the pap collection technique? Some practices are using a broom only. What is the best technique to use?
There are 2 liquid-based pap tests, and I'm going to mention them by name because ThinPrep was for a long time the only one approved for HPV testing. SurePath has now received FDA approval for HPV testing. So the SurePath uses the broom, and the broom is meant to be able to get a sample from the endocervical canal as well as the ectocervix. And that whole broom gets broken off, not broken, but whatever, snapped off, dropped in. The cytobrush and spatula, I always make a point, and I learned this from Ralph Richard, who was considered kind of the father of CIN and nomenclature, and I do the spatula first, and as I said, if you grossly see it's the cervix, you know that line where squamous and glandular meet, you might miss if you only turn the spatula at the canal. So you want to bring it out. That's where lesions occur. That's where the action is. The cytobrush, just a quick tip, the cytobrush, the one that gets supplied with my liquid-based PAP, has a little loop at the top. And another brand ends in a straight point. And that little difference sometimes, because remember, what cells do we want to get? We want endocervical cells. Those are the cells where disease happens, and we want to get that sample. So the brush, just quickly, sometimes if I can't get the looped brush in to the canal, you think about an older woman, the canal gets more narrow. I keep on hand some of those end in a point brushes, and sometimes that little difference I can get in. Thirdly, I have a little mini dilator set where the diameter of the smallest one is actually thinner than a brush. So with the ThinPrep, we're going to do the spatula, the brush, and I vacillate the spatula onto the brush. And if you can't get the brush into the cervical canal, I would keep some brushes around. If it won't go in, try to get more cells under cervical component. Was there another question? Are we?
Does HPV vaccine provide lifetime immunity? And also for those women who have completed HPV series, do they still undergo the same testing guidelines for HPV?
Yeah, absolutely. First of all, the long-term studies, there's a Nordic study on the vaccine. There has not been yet seen any waning immunity, so there's no need for booster yet. Vaccinated women need to be screened according to guidelines. I did mention that as the vaccinated cohort increases, there may have to be a change because 16, 18 lesions tend to be bigger, more visible at colposcopy. And as those lesions are prevented through vaccination, but we have other type lesions, they're harder to see and harder to identify. So that's where HPV testing is so critical in the vaccinated population.
Why aren't HPV positive women vaccinated?
Well, the vaccine is not a therapeutic vaccine. It is a preventative vaccine. And we know that I think I may have mentioned, the immune response is most robust in our youngest, 11 and 12-year-olds, and only approved to age 26. There's been data presented to the FDA. It's not yet, there has not been approval for above 26. But your young women who've already had HPV, now that we have a 9-valent vaccine, even with the 4-valent, it was seen in the studies that most young women had not been infected by all the vaccine-relevant types. So there is a rationale to vaccinate even women who've had some HPV disease, even LEAP treatment.
Nancy, I had a couple of questions here about virginal status. Some have asked whether or not if they're virgins, they need to undergo PAP and HPV testing, and others saying if they're virgin, how do you convince them that they do need to go undergo HPV testing? And they're worried the women are concerned that they'd no longer be virgins if they have this testing.
Yeah.
So there's two
it's
sides.
always, such a great question. Guidelines are meant to protect women, and the guideline for starting screening at age 21, which was increased from age 18 and then 3 years after first intercourse, was always meant to cover women who may have had a abuse situation, a situation of unintended exposure that they're not willing to share. So we have to use clinical judgment. I just had this week. I had a young woman who had never been active, age 26, and I think there was a point that I felt, I explained, and I will say again, cervical cancer is caused by HPV. But HPV is a skin cell virus, and there's a field effect. When a person is exposed and infected, the virus isn't just at the cervix or just at the vulva. And that's why I said it can get to the anal canal without anal intercourse. So we have to be cautious for one reason, because the definition of what's sex and what's intercourse and skin-to-skin contact, and we don't change guidelines for women who have sex with women, and we don't change guidelines based on sexual history ever. But when I examined that woman just a few days ago, she wanted me to do this, and I felt it was a little bit irrational to put her through anything that was physically going to be in some way harmful to her based on her history. And I worked with her and felt her out, and she wanted me to do this. I felt it was a bit of an exercise because theoretically I would not expect she had precancer. But I will say in the end, when I talked with her and I said, I don't have to do that based on what you're telling me. She wanted me to, and again, there needs to be a communication.
I'm going to finish up with 2 questions. A lot of people asking questions. I'm really happy to hear this. So someone asked, just to clarify, is HPV infection transmissible to the partner? And second, if questioning whether or not no PAP for 3 years, even if the woman has had a positive history of precancerous cervical cells in the past. Can you comment on those 2?
Yeah, first of all, can it be transmitted to a partner? That was the question?
That was the first question.
I think that what's tough is we've all dealt with, for example, herpes, issues of disclosure. And I'm very cautious. We all know there's been examples of litigation. I think with HPV, we do like to say it's ubiquitous. Most everyone's infected, but most everybody doesn't know they've been infected. And we are rational to look for precancerous changes that it causes. So yes, it can be transmitted, but in issues of disclosure, this is a personal choice. I don't think we treat, when a woman comes in and says to me, I want to be tested for everything, we don't test for HPV as an STI. We do it as a cancer prevention strategy. So I'm getting a little bit off the topic to say, yeah, people transmit HPV. That's why it's ubiquitous. Most everyone's infected. But the good news is most everyone clears. In terms of the second question, I mentioned that after treatment of precancer, women must be followed for 20 years. The initial follow-up is PAP plus HPV at 12 months and 24 months. And if she's negative at both of those visits, then she can be followed with a wider interval. But she must be followed for 20 years, which is significant if she becomes 65 and hasn't accumulated those 20 years yet.
Cool. I know there's probably some other questions, but let me say thank you very much for a great talk on this subject. We're going to take a 10-minute break. We're a little bit late, but I think that's okay. 10-minute break, stretch your legs, go to the bathroom, and we'll be back to finish the last lecture. Thank you very much, Nancy. Okay, everybody, we'll see you, audience at home, in 10 minutes.